need more, I'll be even more specific, okay? Because there's other things you can do. Go look at who sponsored legislation, you know, that in your state that set the scope of practice for nurse practitioners. You know, the people who voted in favor of expanding the legislative history of the statutes. In fact, the state associations should, your nurse practitioner association at the state level should know, you know, what legislation got passed and who sponsored it and who voted for it. They are natural people to go talk to.
But what if your state, like Pennsylvania has a very active one, Ohio itself has a very active one. What if your state does not have an active one?
Then become active.
Make one. That's what you're going to tell me.
Okay, for all you Pittsburgh people, the Pennsylvania Coalition of Nurse Practitioners yearly conference is out here this year.
Yeah.
When?
It's in November 3rd to the 5th, 2011.
Yeah. And the state and the national organization is the Academy of Nurse Practitioners, the American Academy of Nurse Practitioners. So get involved with them. It's only $100 a year, and they will point you to your state association
In addition,
and help you get involved.
if you have a Medicare federal level question, that association will have at least one lobbyist, if not more. They're often very accessible.
And the Academy's great. They will
If
help
you send them an email and say, look, you know, this may be an important issue for nurse practitioners nationwide. We want to clear away Medicare hurdles to nurse practitioners being medical directors of nursing homes. You know, you want to help. My guess is they might. And this sounds like a real winner.
Okay, so I'm on their site, and it says, good news for nurse practitioners. The Joint Commission's new primary care medical home accreditation standards. Click here for link to the announcement. So there is all this stuff that's going on. In our defense, we've been busy doing our capstone
That's right.
to keep on top
What
of
is that under the?
You don't have to say about that.
What website is that on?
that.
Finish your capstone.
Yeah, really.
Right.
First thing first.
What site is that on?
The Pennsylvania Coalition of Nurse Practitioners, but then it directs you to a link at the AANP. I'll print some of this stuff out and need copies for tomorrow if you want.
That'd be great. Did I ever tell you what the best dissertation, PhD dissertation was? Finished.
Yeah.
Okay. And I told you about the worst doctor in his medical school class.
Doctor is still there.
Call him doctor.
Yeah.
You used that joke the other day for a friend of mine came in last at a triathlon.
Yeah.
What do you call the person who comes in last at a triathlon?
She did.
Triathlete.
She did. That's right.
Okay.
Okay.
Doctor.
Has anybody read the Institute of Medicine? You know about this stuff, right? They browbeat you with it?
Yes.
Okay. So, to err is human, do you know the context? Did you ever read it? The context of it was, what, drug prescribing in 2 states.
Oh, yes.
The first, yeah, that's to err is human. To err is human was the first IOM study. They concluded that they extrapolated that 98,000 deaths occur in the United States every year as a result of medication errors. But they extrapolated from 2 states. Crossing the quality chasm, I think, is the one where they talk about patient-centered teams and stuff like that, or spin-off from that. You've read the stuff about teams, right? Teams and teamwork. Do you have a course on that?
Yes.
Any good?
Yes.
Okay. I'm sorry.
It was at the wrong level and addressing the wrong issue. It did not address that our level.
I'm very sorry.
We didn't think it could have been very good, but not where it was at. It was like that.
There's great organizational theory out there about how teams work.
And that would have been good. That system, I mean, it could have been a fantastic, but the content was more a hospital-based nursing rather than.
Okay, because some of the stuff you guys were talking about the patient-centered home, yeah, basically, I do not think a physician should run that team. I'm not sure a nurse should either.
Yeah, I don't think so.
Okay, now, care coordinator, maybe we have to invent a person
I
who
think
needs
it's
to run it.
almost a new position.
Yeah,
That patient
It
center.
really is.
it requires training that people don't have yet. I agree.
Because there's so much
Or
more.
a nurse, because I was
It's almost like
thinking
a
one
new business,
that I.
business.
I think
No, it's run by a nurse.
You're aware of lots of national efforts, I think. You guys follow this stuff, right? Institute for Healthcare Improvement, right? The 5 Million Lives campaign, I talked about that a little bit yesterday. They have an annual forum on quality improvement in healthcare. Anybody been to one? They got a website. That's a good organization. All these are. I mean, one of the questions I have is there a lot of overlap here? And why is there so much of this? National Patient Safety Foundation, that one I think is actually funded by the insurance companies. It's an interesting one. I think the former head of Kaiser runs this. They have an annual Patient Safety Congress. And nobody works through the VA in this cohort, right? VA's really, really done a lot of good stuff in patient safety. Their lift technology stuff is really neat too, and the robotics. Have you seen any of that?
No.
They're starting to use robotics for coronary surgery, heart surgery.
We do that for our.
They do, you do it, okay.
Surgery. Single dose.
The VA has a cut on the fact that they want to reduce harm to patients, not to eliminate medical errors. And I'm going to talk about this a little bit. They do something called root cause analysis. That's the Six Sigma stuff that I talked about. I'll bring it up a little bit later. And they're big believers in the use of technology to reduce medical errors. What do you guys do with technology? Do you have local events? You have patient sitters. You know there's a literature on patient sitters? Do you know what the literature concludes about sitters? They don't work.
They watch TV and they're nursing everybody.
They're not doing it. I've had patients fall out of bed while they're in the room.
Yeah.
Well, worse, we had one patient gets up out of bed, sitter goes over, patient grabs sitter, takes them both down, and they both broke bones.
I like the bed alarms.
We have bed alarms.
Yeah, the states come around and take it away.
We have concluded, after 6 years, that we can't predict patient falls with our current knowledge.
Right.
Cannot predict.
It's tough.
Joint Commission, National Patient Safety Goals,
Right.
set no, but suicide's an interesting one. Have you read that? The patient safety goals on suicide?
Yeah.
And by the way, suicide, violence in the emergency room is a huge problem. Huge.
Yeah.
Did you follow what happened at Hopkins?
Yeah.
Patient shot doctor.
Really?
About every other month, we get some psych patient beating up on an emergency room person.
Any shot is another shot.
Yes, yes.
Not long ago, we had a patient jump out the window at Lancaster County from the 8th floor. And, you know,
There's an ENP student who told a story on her first day as a nurse, went into a patient room and the patient was at the windowsill and she started to talk to the patient jumped right in front of her first day as a nurse.
that's a bad way to start our career.
I had a patient hang himself with a shower curtain when I worked in the building. Hung himself with a shower curtain. Dead. When there is dead.
He wasn't on a psych ward. He was
I think that's a misnomer. Most people think that people have psychiatric issues are being, they're on a psychiatric or treatment under attack. The other floors and other settings, they're actually.
That's right.
right.
That's exactly right.
Yeah, really hard for them to be on a psych ward for most places. They
Well,
can't.
most of these people may not have psych histories. You don't have to, all of these behaviors don't have to be treated with psychiatric diagnosis.
No, and some of them may be
I'm not
triggered
saying
by
that,
drug
I'm just saying
interactions.
Right.
It's
So
true.
it's brain impairment due to metabolic
Yes.
conditions, and that's not a psych disorder.
Right.
That's a medically induced condition of the state.
By the way, are falls age related?
No.
Not at all. Not at all.
Next door.
What's that?
Covert line drill nurse.
Yes. Joint Commission accountability measures, research. So the Joint Commission is pushing the collection of data in order to analyze this stuff. Process measures associated with outcomes, just not measures per se. You remember your statistics, specificity and sensitivity? We don't understand that in patient safety, at least at our hospital. Basically, what we are looking at needs to be both sensitive and specific. In other words, if there is a medical error of some sort, have we picked it up? Have we got it reported right? And then sensitivity, given that we've gotten a report of it, is that truly a true event or is it a false positive? So there's a lot of that going around here. And then finally, minimizing adverse events. So this is from GCAH. There's a lot more with GCAH. National patient safety goals, patient identification, right? Yeah, identify safety risks of suicide, prevent surgical mistakes. Do you think they're working?
To some degree, I think they are.
How many wrong side surgeries have you ever had?
There's been a couple, but in the history of our facility.
They've gone to almost zero.
Yeah, not that I can recall in the last 3 years that I've been in that.
Almost. Well, hold that thought though, actually. Yeah.
I know, looking at the orthopedic, they're having, they just like they have M&M review constantly, they're marked up all the time.
Right.
They have about 4 people double checking before they do.
And you do time out.
Yeah. So there's, it's pretty.
So when it happens,
Well, you have to go through a lot of checks for order to happens.
What ultimately, once we had a patient, he was supposed to have the right knee done, so he wrote on the right side doctor, left side lawyer.
I had left knee ACL surgery. The surgeon's a friend of mine at State College. And all down my right leg, I wrote wrong leg, wrong leg, wrong leg. So, wheel me in, and he looks down there, and he starts laughing. He says, did you? I said, I looked at him, he said, you think that's what? He said, yeah. I said, what would you have had me do? He said, that.
And I know that, sir.
Yeah. Yeah.
I had a patient that wrote on his other leg, wrong leg, dummy.
Now, in fact, you smile at me, right? Wrong side surgery. It still happens. Say it's 1 in 5 million.
That was my leg, that's probably 1, 2.
That's a problem. But in the overall, I may have it in here for if I'm getting ahead of myself. I tell you how to eliminate all errors. You know how to as well.
Stop recording.
No? Correct, don't treat. Now, is that a good answer? No. The question is, in terms of what I'll call a rare odds event. Did you study rare odds events in statistics? The hit by lightning stuff. Okay? How much money would you spend to avoid being hit by lightning? Every penny you have. In which case you couldn't live.
Because the likelihood of it happening is so extremely slim.
Okay? Do you drive a car? Sometimes it happens. But you want to take a risk because it's low enough for you, even though it's a lot safer to fly. But the rare odds events, and this is something we don't understand in patient safety, a true rare odds event that you cannot predict may not be something you want to spend a ton of money on to avoid. You may want to spend your first big dollars on what I'll call the low-hanging fruit. You've heard that term? I mean, if there's things that happen a fair amount, are really a high-dollar problem, and you can fix with some degree of certainty.
Like post-op infection?
Correct. Perfect. That's why what are the arterial, when they put the IV in the artery, what do they call that? Huh? Yeah, central line, right?
Yeah, yeah.
Central line infections. Right, there's a guy in this town who really showed you could eliminate them. Okay? With good training and having a team of people who do it. And you do it the same way every time. Right? But now patient falls, you can't predict. So putting the bed sitter there doesn't really work. You know. Now, can you go try to develop a science to predict rare odds events about it? Yes. But until you can do the science, the rare odds events, if you spend money on it, it's probably not going anywhere. So, eliminating all medical errors, well, it'd kill us. We have to live with some. What we want to try to do is to be really smart about the ones we go after. And then try to study better what we don't understand about the ones we can't influence. You know, in my committee, you know, we have this attitude by most of the folks on my committee. We want to eliminate them all, and it drives people nuts. I told you about the falls study at Swickley, didn't I? They put in a big falls prevention campaign at Swickley, 3 months. You know, they did rounding with people. They did education. They did all kinds of stuff. Falls went up by 30%. They were devastated. I mean, properly so. Okay, so JCH is in this. AHRQ, Agency for Healthcare Research and Quality. I think I put some stuff in your packet from them. They do some humongous studies on some quality issues. Patient safety primers. I don't know if I put one of those in your packet or not. The medication reconciliations that you do.
That's a joke.
Talk to me. I'm with you.
That's a joke. Because what I'm finding is all nurses do is take a previous admissions drugs and bring them over to this current admission. You know, you can still see on the bottom in the comments, new medication. Well, it was a new medication a year and a half ago. You know, and when I go to discharge a patient, this is not a new medication, it's a different drug, different dose. Or there's 2 of the same medications. You know, there's aspirin 81 milligrams and aspirin 325 milligrams. This is being taken so lightly.
Is it confusing to patients?
What's that?
Is it confusing to patients?
Absolutely.
Because they come in with when they come in, they've had certain medications. You get some stuff in the hospital, and you go home, you get other stuff.
Yeah, and it's generic terms, it's brand name terms,
Yeah.
the patients are confused. This is something that should be done by a clinical pharmacist at the patient's bedside.
By the way, do you have to reconcile in the emergency room? Okay. Do you have time? Serious question.
You know, the nurses are supposed to do that. I find that I do it myself regardless to verify. A lot of times.
Because you trust what you can do.
If I've seen it myself, then I know it's correct.
Yeah.
A lot of times, the nurses will go through something and I'll review it with the patient. They're like, no.
So it's another burden.
I don't consider it a burden.
Okay. Okay. Something else in your skill set. Okay.
That works.
Okay.
They don't do it in our area.
I was just going to mention there's even a bigger problem in psychiatry when patients are discharged and you don't get the information about changes in medication.
Ooh.
Patients are supposed to come in within like 10 days according to insurance criteria for their first appointment back in outpatient. They don't know what they're taking and they don't keep any paperwork to know what they're taking. So the problem is the discharge summary might not be typed for 30 plus more days and sent out. And so it's really disjointed. And in psychiatry, because of patient privacy, they're fighting electronic record. Yeah, you can only keep so much on
We can be so
it.
private, we can't get people to understand what they're doing.
Yeah.
We have a huge problem with the nursing homes because we're not, we're paper, and the other system is electronic. So what happens is when they go to the ER, we send them with, a photocopy of their current medications, and I don't know what happens in our ER, they just don't do MedRec or what exactly happens, but they'll be discharged on medications that they were on 5 years ago. Because that
that's
was what
what's in
was
their
in the
system?
computer system from 5 years ago when they saw their primary care provider last time in the office. And there's no med reconciliation that happens at all. And I tried to talk to people from I have a big problem with that too. And now they're cracking down on medications, because I'm actually getting phone calls from our performance improvement at the hospital. So if I dictate a discharge summary, and what I dictate in my discharge summary doesn't match what I've written on the discharge sheet, they want me to change it. And that recently happened, and somebody had crossed off something on the discharge sheet, and they wanted me to change it, because my initials behind it. They said, no. So, well, then I don't know why it's crossed off, and whatever. They're cracking down on that. And the solution, what I find, this is what I think they should do. I think they should hire a team of nurses, RNs, that when patients come through the emergency room, I don't know how many RNs it would take, I guess it depends on your facility, but I think one nurse, any patient that's admitted to the hospital, they need to have a nurse that does that, the medication reconciliation sheet that's not accurate at all, hardly ever even filled out in our hospital. They need to have one nurse. This would save the hospital a lot of time and a lot of money, because what happens is the patients get admitted, and the nurses are busy seeing their regular patients, and now they're responsible to obtain this medication reconciliation, but they're busy, lazy, whatever, but mostly busy. I'm not trying to fault the nurses. And so they go by whatever the sheet was that you had, or then I come and see them from a cardiology standpoint, and then I'm like trying to figure out, well, we had them on amiodarone before. Why were they on amiodarone? She's in the nursing home, not on the amiodarone. And then you're trying to play like this investigator. So I think there should be one nurse that handles whatever patient comes admitted, and they have responsibility for whether they need to call the pharmacy, where they need to obtain those records of that patient, so there's accurate medication reconciliation, and then the same thing needs to happen at discharge. They need to
Going back to the old model,
they
having
need
an
to ones to make sure it's accurate at discharge. That's what I think would, I think it would improve, I think it would improve the medication adherence and errors.
Sure.
Well, I was just like,
Okay.
I'm just laughing because our hospital, diabetic network, which is simplicity, where all records are uniform across the entire hospital system. And this is why the big push for electronic medical records is that anybody at any time has access to the current, most updated patient database. And psych, the only thing that's pulled out of psychiatry, this was a big issue when we implemented it, is that you pull out the personal treatment, the ongoing therapy drugs, but everything else, you have little lock bars, so they know who goes in and who isn't, and you get permission if you need to go to those records. But this is the big push for EMRs, which is almost like ludicrous, because everyone's talking about all these issues. But also there's issues with starting these and asking people to document it correctly. There's technically all the meds pop up, like psychiatrists have access to everyone's meds for every specialty right there in front of them. They see the interactions. So it takes a while for the system to work it out. I love that system. So I don't know how, I love right as it got implemented. I mean, I was there for about 6 weeks, but so I don't know if there's been fallout or not. However, that in theory, this is why the big push for EMRs.
Now, we have EMR, and we have a two-tiered system. We have EMR. We also have an admission center. So patients from the ER can go to the admission center where there are nurses just like she's talking about that do the admissions and reconciliation, that, or they can go to a PC or an ICU where the nurse does it at the bedside. However, I believe in a facility such as ours, a 600-plus bed unit or facility, we have clinical pharmacists 24 hours a day. Those are people who are specifically trained in medications, and it should be their job to reconcile those medications with patients. That's what they're being paid.
Right.
One more.
There's one piece I don't understand with electronic medical records. It's wonderful if you are in that system.
Well, that's what's happening here.
Yeah, when you're outside of the system.
What's happening with
Right,
you?
there's nothing.
Yeah,
You don't get, you're not part of the docs.
Yeah, they were trying to get one more, say like 4 years ago, but the problem is you're giving them all the information, they haven't seen an engagement provider for 4 years. And so there's stuff in the system from 4 years ago.
Well, and your nursing home's paper.
Minors
So it's
from
not
paper.
there.
So
You
it's
don't
not there,
exist.
and nobody's looking at these two things, and they're literally putting people on things that would be contraindicated and discharging them. And you're going, no, we can't do that.
And what I'm seeing is like an independent agency